be discussing tobacco and cannabis use from a behavioral health perspective with a focus on policy, clinical practice, and emerging products in Kentucky. And by the end of this presentation, I hope you'll feel confident in describing current trends in tobacco and cannabis use among people living with behavioral challenges, be able to identify key policies and regulatory changes shaping product access and use in Kentucky, and be able to discuss implications moving forward. So we'll start with tobacco use, and despite decades of prevention efforts, tobacco use remains a leading cause of preventable death, and the burden is especially concentrated among our clients with a mental illness. So the tobacco products people use today look very different than cigarettes alone. Many of our clients may not identify as smokers, even though they regularly use high-dose nicotine products. So there may be a disconnect for how we screen for use and what products our clients are actually using. So to get a clear idea of the type of products that our clients use, we can group tobacco products by how nicotine is delivered. Combustible products such as cigarettes, cigars, hookah still carry the highest health risks, but non-combustibles such as smokeless tobaccos and nicotine pouches, and electronic products such as e-cigarettes and vaping devices are driving nicotine dependence. And currently, flavored disposable e-cigarettes dominate the market, especially among younger adults. Many of these appeal to this demographic because they offer a variety of flavors like fruity or dessert flavors. And there's even several types of unauthorized smart vapes with built-in technology. So you can imagine that these are particularly attractive to younger adults who may already have high screen time use because they're able to play music, they can customize their wallpapers, have built-in games. They can even take pictures and make calls and send texts. And nicotine pouches are also gaining popularity. They're the most rapidly expanding nicotine product category, and their use among young adults have nearly quadrupled since 2022. And that's driven by factors like discreetness, not having to spit like with chewing tobacco, and having many different flavors to choose from. And to be clear, even though these e-cigarettes and pouch products are among the most frequently purchased, the majority of them are illegal under federal law. To date, the FDA has authorized the sale of 39 e-cigarettes, all of which are tobacco or menthol flavored, and 20 nicotine pouches have received authorization for marketing. But with these, it's important to note that while these products are authorized to be sold in the US, it does not mean that these products are safe, nor are they FDA approved. So this is an important distinction for our clients who may be interested in discussing cessation and are considering using these products as a form of nicotine replacement therapy. We have to educate our clients that this is not a cessation tool per the FDA, and we have other forms of FDA-approved nicotine replacement therapy and cessation medications available. And something alarming we've observed in recent years is the increase in product size and nicotine concentration in e-cigarettes. So this chart shows the total milligrams of nicotine sold in billions by product type between a 4-year period. The total amount of nicotine sold surged by about 250% between February 2020 and June 2024. And so that's actually more than 7 times the actual sales of e-cigarette unit sales. And you can see in blue, disposable products continue to account for the majority of sales. And this is problematic because nicotine alters reward pathways in the brain that are especially disruptive for people with mental illness. Specifically, after nicotine use, you get a release of dopamine, which can improve mood and give feelings of pleasure, and this reinforces use. But with repeated use, a person might develop tolerance and physical dependence, leading to withdrawal. So for our clients with mental illness, some of them may be stuck in a cycle of using nicotine, feeling anxiety and stress during those withdrawal periods, and then using more nicotine to restore those feelings of pleasure and calmness. But they end up worsening their anxiety and other symptoms. And so the harmful effects of tobacco products are well established. We know that tobacco use is linked to cancers, cardiovascular and respiratory conditions, among other ailments. But then we consider that these emerging nicotine products, which have high amounts of either tobacco-derived or synthetic nicotine, so in addition to addiction, nicotine alone poses several health hazards. There's an increased risk of neurological, cardiovascular, respiratory, and GI disorders. It affects the immune system and reproductive system. So while some of these newer products may be tobacco-free, they can still have significant adverse effects on overall health and worsen the behavioral health challenges of our clients. But now let's shift to cannabis, which is often viewed very differently by our patients. Legalization and commercialization has changed potency, access, and patterns of use within the past few decades. So with cannabis, it's important to understand it as it exists today in today's commercial landscape. And when we approach cannabis use among our clients, it's useful to differentiate cannabis terms into the two common classifications, either hemp or cannabis/marijuana. Both come from the cannabis sativa plant, but differ in their psychoactive compounds and legal status. Hemp can have a high concentration of CBD, but it must have less than 3% of THC, which makes it non-intoxicating and federally legal for industrial uses. On the other hand, cannabis or marijuana often refers to the products with high THC content that's capable of producing a high, and this is what's regulated for medicinal and recreational use. And cannabis products are incredibly diverse now. We can categorize them as combustible or heated, such as pre-rolls and joints, to non-combustible, such as edibles and concentrates. They can also be delivered in electronic products, just like with tobacco, such as in e-cigarettes and vaping devices. And when we examine the current market, we see that the most popular cannabis products are those that can be administered through a multi-system route, which are cannabis products designed for multiple routes of administration, so like concentrates and tinctures. And the next most popular are single system products that are either inhaled or eaten. When we look at products sold by cannabinoid classification, we see that more than half of cannabis products sold contain THC as a primary component, and about a quarter have CBD as their main cannabinoid. And flower buds remain the most popular type of product category, followed by cartridges, then joints. So when someone consumes a cannabis product, THC or CBD is delivered to their brain, which modulates neurotransmitter pathways, which include dopamine and serotonin. And these can have varied effects, but most concerning for our clients are products with THC, which can cause feelings of pleasure or the high, and this high causes strong cravings and a desire for repeated use. But over time, the body can become less sensitive to THC and requires higher and higher doses to achieve those same pleasurable effects. And with this, you may see tolerance, dependence, and cravings, eventually leading to a cannabis addiction. And with cannabinoid receptors in both the central nervous system and in peripheral tissues, the health effects of cannabis are widespread. Cannabis use is linked to cancers, cardiovascular diseases, neuropsychiatric disorders, and reproductive conditions. But more importantly, it's crucial to consider that products differ in their effects because of their THC and CBD contents. They may contain different ratios of THC to CBD, or they may contain either alone as an isolate. For our clients, it's crucial to evaluate the safety profile of cannabis products relative to THC content, as there's a lot of psychiatric safety concerns regarding THC. For example, it's not uncommon for THC users to experience anxiety and aggravation, and in more extreme cases, panic, paranoia, and other forms of psychosis. So THC use is actually contraindicated among those who have a family history of schizophrenia or other psychiatric condition or pre-existing psychotic condition, as THC has been linked to the onset of psychosis or the exacerbation of psychotic symptoms. THC also worsens other mental health disorders. For example, in addition to schizophrenia and other psychotic disorders, THC has been linked with earlier onset of depression, exacerbated symptoms of bipolar disorder and anxiety, and among individuals with PTSD, it can worsen the severity of their disorder by increasing those negative symptoms, including anxiety and panic. So, from a behavioral health standpoint, addressing cannabis use, especially those with high THC potency, is crucial to supporting symptom management and personal recovery for our clients. Now we'll delve into tobacco and cannabis co-use. And we have to consider that many of our clients meet the criteria of substance use disorder for tobacco or cannabis use, or both, without recognizing it. And substance use disorder, as defined by the DSM-5, is a problematic pattern of use leading to clinically significant impairment as characterized by at least two of the following within a 12-month period: taking greater and greater amounts of a substance, wanting to but being unsuccessful in stopping, spending a lot of time using, having cravings, failing to fulfill major role obligations, having persistent interpersonal problems due to use, giving up other activities to use, using in dangerous situations, using even when they know a substance can worsen a physical or psychological problem, tolerance, and withdrawal. So we may see these disorders for one substance alone, but co-use disorders may easily manifest in our clients due to a variety of factors. And so there's this idea of a twin landscape of tobacco and cannabis, which refers to the way that these two substances now exist within overlapping commercial product environments. Their shared modes of delivery, combustible, electronic, and non-combustible products, creates a structural and behavioral condition that promotes co-use. So with combustible products, we see overlapping product forms with behavioral cues. There's a similar sensory cue with that hand to mouth motion, the ritual of inhaling and exhaling, and this may cause cross cue conditioning, such as nicotine cravings might be triggered by cannabis cues and vice versa. With electronic products, we see converging device technology. Some of these products are identical or interchangeable. So with some devices, they can just swap out cartridges to switch between whether they want nicotine or if they want to use cannabis. And this promotes dual use because the more familiar they are with these devices, the lower the barrier is for trying the other substance. So that makes our transition to co-use easier. Finally, with non-combustibles, such as edibles, pouches, and oral products, co-use is promoted through normalization and expanded access. These are increasingly more accessible, and there's a decoupling from smoking stigma. So a lot of these products are discreet and flavored. And unfortunately, sometimes some of our clients may perceive them as a safer form of consumption than combustible products. So sometimes harm reduction narratives contributes to co-use because they may unintentionally minimize the health risks associated with these products. And this slide illustrates the continuum of tobacco and cannabis use across time. On the left, we see temporally distant, non-overlapping patterns. On the right, we see temporary close, overlapping, and simultaneous use. And the more temporally close, the greater the likelihood of overlapping effects. So starting on the left, some of our clients have a same month, different day pattern of co-use. For example, they might use tobacco on weekdays and cannabis on the weekend. And here you may see a variety of different products used rather than a preference for one type. And then moving along, some of our clients may have a same day, different occasion pattern of co-use where both substances may be used on the same day, but at different times. So for example, they may smoke tobacco during the day and then smoke cannabis at night. And products often share a similar route of administration like combustible and combustible or vaping and vaping. And then we move on to more temporally close use with the same occasion. One substance is used immediately after the other, and this is often called chasing. And this pattern can enhance or modulate effects. So, for example, nicotine might intensify the effects of cannabis, and shared routes of administration are more common here. And on the far right, we see patterns of use that are simultaneous. Here, the effects overlap directly because they're co-administrating the substances. For example, some products include spliffs, which are pre-rolls that have both tobacco leaves and cannabis leaves in one roll. And this pattern likely carries the highest risk for codependence due to the reinforcement of using combined products. But the key takeaway for this is that co-use is not a single construct and temporal proximity matters. And so For our clients, this has implications for assessments. Simply asking them if they use both may miss clinically important patterns and opportunities for tailored cessation approaches. And this figure illustrates natural trends in past 30-day substance use patterns from 2002 to 2019 among the general population. While exclusive tobacco use in orange has declined substantially over this period, there was some increase in exclusive cannabis use in green, and the co-use of cannabis and tobacco shown in blue demonstrates a significant increasing trend among the general population. So when describing the prevalence of co-use among the general population, I want to emphasize how common cannabis use is among people who already use tobacco. Nearly half of young adults smokers, so about 48% of those aged 18 to 24, also report using cannabis in the past 30 days. And among adults 25 years and older, more than 1 in 4 tobacco users report cannabis use. But of note, cannabis use is 2 to 10 times more common among cigarette smokers compared to non-smokers. So this highlights how strongly these substances cluster together in the general population. And while tobacco and cannabis each carry significant health risks, co-use appears to magnify those harms. So with using both, especially through combustible routes, we get increased toxin exposure. And although co-use is usually associated with a particular sort of administration route, the more types of products a client uses, the more cumulative toxin exposure they may experience. Co-use is consistently associated with worse mental health outcomes and psychiatric effects, which I'll discuss more shortly. And the relationship between tobacco and cannabis is bidirectional. Each substance appears to increase vulnerability to and dependence on the other. Cannabis use has been linked to greater nicotine dependence and relapse risk, while tobacco use is associated with increased likelihood of cannabis initiation and dependence. But more importantly, some evidence suggests that quitting one substance significantly increases the likelihood of being able to quit the other. So this suggests that we should assess and treat both substances together, as targeting one may influence better outcomes for the other. So I've already mentioned some of the impacts of nicotine and cannabis use on people living with mental health challenges, but we'll delve a little deeper into the trends and implications for our clients. But mental illness involves clinically significant disturbances in thoughts, emotions, or behaviors. And serious mental illness goes a step further, in which there's major functional impairments that interfere with daily life. And between 1 in 5 to 1 in 4 people in the US live with a mental illness. Among them, about 5.6% live with a serious mental illness. And historically, we've seen a significant gap in smoking among people with mental illness versus those without, and this gap has continued to persist. Generally, cigarette use has declined over the long term, with smoking rates falling about 70% among adults in the US. But when we consider our clients with mental and behavioral health challenges, we generally do not see that same significant decline. So their rates of smoking, which is already elevated to begin with, remain high. And we see high rates of cigarettes use, particularly among those with serious mental illness. They're roughly about 2 times more likely to smoke cigarettes. And their rates can be as high as 85% for those with schizophrenia. So this figure shows substance use disparities by mental illness status, either serious mental illness in red, any mental illness in orange, or no mental illness in green, using data from 2024. And when we focus specifically on marijuana and tobacco, we see that more than a third of individuals with any mental illness use marijuana and tobacco. And across both substances, those with a serious mental illness have higher rates of use. So again, these findings highlight how cannabis and tobacco use cluster within this population experiencing mental illness. And data is still emerging on rates of tobacco and cannabis co-use among people with mental illness. So this is an area that requires further research, especially as we expect to see changes in prevalence rates due to policy shifts across the US. But people who use both tobacco and cannabis in orange report anxiety and depression at much higher rates than people who use neither substance. In fact, co-users were nearly twice as likely to report anxiety or depression compared to non-users. So this tells us that using both substances together may be linked to greater mental health challenges, which is important for screening and treatment with our clients. And we see similar patterns emerging among youth. This slide looks at internalizing disorders like anxiety and depression, where distress is directed inwards, and externalizing disorders like ADHD or oppositional defiance disorder, where there's outward behaviors like impulsivity, aggression, or rule breaking. But youth who were concurrent users in red and used both tobacco and cannabis use had the highest levels of both internalizing and especially externalizing problems. For example, over 60% of concurrent users reported high levels of externalizing problems compared to about 48 among single substance users and 30 among non-users. And the study reported that even after adjusting for other factors, youth who use both substances had nearly twice the odds of more severe externalizing problems compared to tobacco-only or cannabis-only users. So this study suggests that co-use in youth may be particularly linked to behavioral dysregulation, and so that reinforces the need for early identification. So given how common and sometimes unrecognized tobacco and cannabis use disorders are among our clients, it's important to understand how evolving tobacco and cannabis policies and product landscapes may be shaping use patterns and behavioral health outcomes in Kentucky. Okay, so these next two slides are intended to provide a snapshot of the overall tobacco cannabis use trends in Kentucky and a strong connection between substance use and mental health. So just looking on the left with adult tobacco use, currently about 17% of Kentucky adults smoke cigarettes daily, but the rates are much higher among those with mental illness. And this is followed by e-cigarettes, then smokeless tobacco. Among youth, e-cigarettes are the most common nicotine product, followed by cigarettes, then smokeless tobacco. And tobacco accounts for about 2/3 of behavior events in public schools. So this is documented instances of infractions that disrupt learning, in this case, having or using tobacco products during school hours. And importantly, youth experiencing serious psychological distress are significantly more likely to use e-cigarettes and cigarettes. So looking on the right now with adult cannabis use, nearly 10% of adults report cannabis use, and almost half of those are heavy users. So this means that they use cannabis at least 20 of the days in the past 30 days. And most consume cannabis by smoking. About 4.5% of youth report cannabis use, and this accounts for over 22% of school behavior events. So just a quick comparison, tobacco and nicotine made up the majority of behavior events, but cannabis comes in second and constituted the second most common behavior events in Kentucky public schools. And similar to trends we see with tobacco and nicotine, youth with serious psychological distress are 2.5 times more likely to use cannabis. And something to note is that between 2023 and 2024, cannabis-related poisonings among Kentucky youth rose 43%. So these were any emergency room visits that involved cannabis products or in which cannabis contributed to the visit. They saw instances of cannabis-related psychosis, hyperemesis, in which they couldn't stop throwing up, and other reasons for visits. And this rise in cannabis-related poisonings may be due to both the increase in product potency and the availability of products that are packaged in ways that may be enticing or mistaken for candy by young children. And then when we look at the groups with the highest prevalence of use in Kentucky, we see that tobacco use is the most common among adults aged 45 to 54, those with a high school education or less, individuals in the Appalachia region, and those earning under $25,000 annually. Gender and race differences with tobacco use are minimal in Kentucky. When we look at cannabis use is highest among males, young adults aged 18 to 34, individuals with lower educational attainments, and Black adults. Central Kentucky shows the highest regional prevalence and use. When we look at reasons for use, use is mixed in motivation. About 43% report both medical and recreational use. So this highlights overlapping purposes rather than purely one or the other. And when examining co-use status in Kentucky, current smokers stand out in having higher rates of cannabis co-use. They're the only group on the far right where heavy cannabis use, shown in red, exceeds occasional use. So even after adjusting for demographic and socioeconomic factors, current smokers were nearly 5 times more likely to use cannabis compared to never smokers, and former smokers were more than twice as likely. So we observe a strong and persistent relationship between cigarette smoking cannabis use, particularly among those who currently smoke. So, given the burden of tobacco and nicotine in vulnerable populations, regulation becomes a critical prevention and mitigation strategy. Kentucky implemented new tobacco policies that took effect in January 2026, and this legislation established a new division of tobacco, nicotine, and vapor product licensing to oversee sales and enforcement. So retailers must now obtain a specific annual license to sell authorized products. It maintains a 21 years of age or older purchase restriction. It allows compliance inspections and introduces escalating penalties for retailers who sell to minors. And notably, they also take half of those collected fines and reinvest it into youth education on the dangers of tobacco and vaping. And the Kentucky vape ban takes a more targeted approach by specifically limiting which vaping products can be sold in the state. And the goal of this law was to reduce underage vaping by removing flavored disposable products with colorful packaging that tend to appeal to youth, such as fruits and the candy flavors and those smart vapes. So currently only tobacco and menthol flavored e-cigarettes and vapes are authorized to be sold. And with these restrictions, the law also aims to introduce some level of federal safety review and quality control since many unauthorized products have unknown contents. This law also requires Kentucky to create a database of all tobacco nicotine retailers, which further strains enforcement and compliance checks. And importantly, the penalties apply to manufacturers, wholesalers, and retailers, not the individual consumers. So this has the effect of keeping those selling these products responsible and in compliance with regulations. So while these state-level policies straighten product regulation and retailer oversight, it also works alongside federal strategies. For example, the SINAR program is a federal state partnership designed to reduce youth access to tobacco products. Under this program, states are required to enforce laws prohibiting tobacco nicotine sales to individuals under 21. They must conduct annual unannounced compliance checks at retail outlets and report those findings. And to remain in compliance, states must keep retailer violation rates below 20%. And in addition to monitoring and compliance, the Kentucky Signer Program provides free online training and education material to tobacco retailers and vape shops through their Trust program. And just to illustrate the efficacy of Kentucky Signer Program, here's a chart that was taken from the Kentucky Gov webpage. But it shows that the first SINAR inspections were conducted in 1997. And since that time, Kentucky's violation rates have averaged about 8.2%, which is below the 20% federal threshold. Here's an example of the constantly changing policy landscape. So as a lot of you on this call are probably aware of or involved in, it's important to address proposals that are trying to move our state in a different direction from regulation and protection. House Bill 194 would exempt cigar bars, some local smoking-free laws. It would prevent cities or counties from enforcing existing indoor smoking bans or passing new ones specific to cigar bars. So this means that cigar and pipe tobacco smoking could be allowed indoors, even in communities with comprehensive smoke-free policies. And as of February 2026, the bill has been referred to the Senate Committee on Committees. And so this is just a clear example of how quickly the policy landscape can shift and why sustained engagement and monitoring matters for our clients. So moving on to cannabis, this slide summarizes the current cannabis laws and policies in Kentucky. Medical cannabis became legal as of January 1st, 2025. There are regulations regarding forms of use and who's eligible to participate in Kentucky's medical marijuana program, which I'll discuss shortly. And using recreational cannabis remains illegal statewide, including possession and sale. Hemp-derived products, including CBD and certain Delta-8 products, are legal if they contain 0.3% or less of Delta-9 THC. And similar to medical cannabis, these products are subject to testing, labeling, and age restrictions depending on product type. So Kentucky has taken a big step to increasing access to cannabis products with THC by implementing a regulated medical cannabis program. The Kentucky Medical Marijuana Act took effect last year and allows registered patients to obtain a medical cannabis card with a physician's recommendation. And smoking is prohibited, which reduces high-intensity combustible on THC exposure and associated respiratory risks. Approved products includes oils, tinctures, edibles, and vaporized forms, but just to note, patients under 21 cannot purchase vaping products. The program also establishes 30-day supply limits, which are defined in part by THC quantities. And so this supports controlled exposure rather than unrestricted recreational use. And these products may be licensed and regulated, which helps standardize potency and reduce unpredictable THC concentrations, which again is very important for our clients with psychiatric disorders. And from a behavioral health standpoint, this creates a more controlled environment for THC exposure, but it still requires careful screening, monitoring, and patient education, especially again for those clients with anxiety, mood disorders, psychotic disorders, and co-occurring substance use. Kentucky also regulates hemp-derived cannabinoids. These laws establish licensing, testing, labeling, and promotional guidelines for industrial hemp production and hemp-derived products like CBD or Delta-8. Again, legally used products cannot contain more than 0.3% of Delta-9 THC. But for our clients, the wide availability of hemp-derived cannabinoids, often sold outside of dispensaries, raises important questions about THC exposure, again, product potency, youth access, and co-use with nicotine. So online sales are also regulated by state and federal laws, and this serves as another access point that can increase use among our clients. Under current law, medical cannabis can be delivered by licensed dispensaries directly to registered cardholders, which increases access while maintaining regulatory oversight. Shipping recreational cannabis across state lines remain a federal offense regardless of individual state legalization. Hemp-derived cannabinoid products operate under a different legal framework. So these products may be shipped from online retailers if they comply with the federal farm bill. But with the 2025 Appropriations Act set to take effect in November of this year, this will tighten regulations by applying the 0.3 THC limit to total THC concentration. It'll implement a strict cap of 0.4 milligrams of THC per container, and it will also ban synthetic and chemically converted cannabinoids. So collectively, with greater access and convenience of obtaining THC products, there's a growing need for provider education, routine substance use screening, and conversations with our clients about how cannabis can affect their mental health. Taken together, these trends and policy changes emphasizes the need for coordinated efforts across prevention, care, and policy to reduce harm and improve outcomes. So first, for prevention, the current literature clearly shows that early access and mental health vulnerability are factors in use, which makes prevention efforts especially critical. Youth prevention offers an opportunity to either prevent initiation altogether or at least delay it during key developmental periods. However, prevention has to go beyond simple education. It needs to address how young people are actually accessing nicotine and cannabis products. So that includes, yes, straightening age verification for online sales, enhancing retail compliance checks, and reinforcing sign enforcement efforts to reduce direct youth purchases. There's also a strong potential to partner with schools, community organization, and youth behavioral health programs to provide developmentally appropriate education about use and associated risks. Finally, parents are essential prevention partners as well. We can support parents with up-to-date information about emerging products. This can empower them to recognize warning signs and initiate meaningful conversations with their children about delaying or avoiding substance use. And for our clients with mental and behavioral health challenges, it's important to integrate prevention messaging into their psychiatric visits. So our clients face higher risks of dependence and adverse outcomes, so prevention messaging should be tailored to their specific vulnerabilities. So for example, with clients experiencing anxiety, we can explain to them how nicotine can worsen their anxiety cycles rather than relieve them. For those with depression, we can discuss links between heavy cannabis use and mood instability. For those with psychosis risk, we can discuss the association between high potency THC and increased risk of symptom exacerbation. So by framing prevention within the context of each client's mental health profile, we can make the prevention messaging more relevant and meaningful for them. And finally, prevention efforts should increase awareness of co-use and how combining nicotine and cannabis elevates dependence risk. Today's products are also far more potent than in recent decades, which makes education about nicotine and THC across product types essential. So some implications for practice. First, screening for use should be a routine part of mental health care done at intake and revisited over time. We should be asking our clients about whether they're using one substance or both, and if they're using both, then about their co-use patterns. And we should reassess at follow-up visits, especially after any medication changes or if they mention any symptom worsening. And based on the screening results, we can offer brief interventions as part of their routine mental health care rather than treating it as a separate specialty service. So, for example, providers may be trained in using the 5 A's of smoking cessation, which includes asking, advising, assessing, assisting, and arranging for smoking cessation care, which is it's an evidence-based framework designed for providers to help individuals to stop smoking. Or they may use motivational interviewing to elicit personal motivations to support cessation efforts. And yes, not every client may be ready for complete abstinence, so harm reduction strategies can be essential. For nicotine, we can help lower the quantity of tobacco products used by promoting FDA-approved nicotine replacement therapy as our clients work towards cessation. For cannabis, we can encourage lower frequency use, avoiding high potency concentrates, and not mixing with nicotine. For youth and young adults, harm reduction might include emphasizing delayed initiation and reduction of daily use rather than only abstinence messaging. And as for implications for policy, first, the constantly shifting landscape will change patterns of product use, so we must monitor and respond accordingly for both substances. For example, we can use state surveillance data to monitor youth patterns and assess changes in product preference and their access points. Or we can track whether the medical cannabis implementation affects recreational or hemp-derived product use. But more importantly, we should be monitoring how many of our clients with comorbid mental and medical health problems may now be using medical cannabis. And evaluating the consequences related to these policy changes will help inform the strategies that we use to support our clients accordingly. And so policy should also ensure our behavioral health system have the capacity to address nicotine and cannabis use alongside mental illness. So for example, increasing Medicaid reimbursement for tobacco and cannabis treatment services, offering funding for tobacco treatment specialist training within community mental health centers, expanding access to nicotine replacement therapy and medications like varenicline in publicly funded clinics, and supporting cannabis use disorder treatment programs as medical cannabis access expands. And finally, policies should also focus on reducing disparities for our clients. So it's important to expand cessation services in Appalachian and other underserved regions where nicotine rates remain high. Perhaps funding culturally tailored prevention programs in communities with higher cannabis use rates, and addressing transportation and broadband barriers that affect rural access to treatments or telemental health services. So, as we think about nicotine and cannabis use in Kentucky, we should consider them as clinically meaningful and integrated aspects of behavioral health care. Use is highly prevalent among our clients with mental illness, and co-use is common. At the same time, products are evolving, nicotine and THC potency is increasing, and policies that affect access and use patterns are constantly shifting. And what this means for us is that behavioral health systems must be active in ensuring we are equipped to meet these challenges. We must routinely screen for both nicotine and cannabis use. We must integrate brief interventions and treatment as part of standard mental health care. And we must stay informed about policy changes that directly shape access and risk exposure, and advocate for policies which address the use burden of our clients alongside regulatory goals. So, thank you for your time and attention.
If you're interested in learning more, check out our website at bhwell.uky.edu.